Hello, everyone. I am Dr. Annalyn Schooley, current president of the Florida Family Therapy Alliance. And despite my background, it is 2026. And I am very excited to have our presentation this evening. And Meredith, would you please introduce our speaker?
I'll be quite happy to do so. I'd like for you to meet Casey Pfeiffer. Casey is a personal friend. She has been my billing specialist for at least 20 years, and she is the CFO at the counseling center where I work, Everyone's Counseling Center. She's had a quite busy season because it's been the end of the year, the turnover to insurance, getting out W-2s, and all of those busy sorts of things. I don't know anybody who knows more about insurance than Casey, and I suggested that she come to be with us. So she is a skilled and patient person and knows a lot about therapists because I
Oh,
think
dear.
she's probably worked for therapists for, I don't know, is it 30 years?
At at least. I think a little over 30 now. We're not going to say how old I
Welcome to the club.
Started when you were 16.
am. Yeah, there you go. That's a good one. Um, Hi everybody. I'm Casey Pfeiffer. It's nice to meet you all. I do apologize. I've been sick for a couple weeks, and so if I hopefully I don't go on a coughing fit. So I am quarantined to my room and my dogs are here. So hopefully everybody stays quiet. Um, I did start in the field at the age of 18, in case anybody was wondering, in Alabama for an LPC who actually taught me everything. That's back when we had to handwrite claims. Nothing was electronic at that point. I'm going to go ahead and share my screen. I don't mind questions. If you have questions, you can ask me. I won't see anybody raising their hand, so I don't think I'm going to be able to see people raising their hand. But let me go ahead and share my
I'll be
screen.
happy. I'll be happy to catch anything that is put into chat. And so any questions that appear in chat, I'll catch it for you. And I will be able to keep an eye on hand raisers. So between Meredith and I will catch all of those things.
That's wonderful. Um, I was asked to talk about health insurance and billing and kind of go over the different things when it comes to those things. So I do have a PowerPoint. I'm not the best at PowerPoint, so if everybody just bears with, I would greatly appreciate it. Um, why don't you go to the next page? Okay. So as you all know, most Americans are enrolled in health insurance to cover themselves and their family. And most of the plans cover mental health. There are insurance plans out there that you pick and choose. So there are insurance plans that do not cover mental health. Those are normally going to be the smaller um, insurance companies. But whenever you're dealing with insurance, just know that there is the potential that it's not covered. Usually, with the Parity Act that was eons ago that came into effect, mental health and medical are combined. So you no longer have just like a mental health deductible or anything like that. You have kind of both. Sorry, I kind of went off on a thing there, but that's just really important to know when you're doing things with insurance that it is all combined now when it comes to deductibles and things like that. You know, you do have some clients that are seen weekly, some are seen bi-weekly, and it's hard for them sometimes to be able to afford the out of pocket. And of course, mental health is, you know, critical care that they need. And accepting insurance does help reduce financial burdens when it comes to that. So that's another good reason to kind of take insurance. Um, Clients also go through their insurance networks to find providers. They also use their primary cares to go, who could I see? And they want somebody who's on their benefit. Um, Clients do seem to feel more comfortable financially with providers who accept their insurance for long-term mental health care. With with insurance, when it's saying some are seen weekly and some are seen bi-weekly, there are times when you do have to see somebody twice a week. And unless they have like a visit limit per year, or a annual dollar limit per year, it is normally okay to see somebody twice a week. You kind of want to do it for a shorter period of time because you don't want to have to deal with audits. I know with the insurance thing that happened for this year and everybody grabbing their own insurance, a lot of providers got worried of people not being able to afford plans. All that happened with the marketplace. I don't know if y'all remember all that, and it scared a lot of people. That only affected individual people who were going to the marketplace for themselves. It did not affect big corporations. Advent Health not affected, those kind of big corporations. So all those people still have insurance. Everything is still fine. So if hopefully that helps kind of with your questions on that. I know I got a lot of questions for that when everything was going on with the insurance. With insurance CB codes, with insurance, you use CPT codes. They are required for billing. I think everybody probably pretty much knows these codes that are here, the 90791, 90837, 90847, 90846. Those are codes that are billable to insurance companies, and they're based on what you did to the session, how long the session, if it's an intake, a family, patient's not present, or if it's just individual. I know a lot of people are also doing telehealth now, and all the insurance companies are now allowing telehealth, and those just have to be billed specifically with these codes. If it's telehealth, you use a 9.5 modifier, and then your place of service would change, which is your POS. That's what they call it. So a POS 10 is telehealth and the patient is in their home. A POS 02 is telehealth and the patient's not in their home. Because, sometimes they're at work and they go into a little cute, lunch break or whatever. So that would be an 02 situation. So if you're going to use a 10 or an 02, you have to use that 9.5 modifier. There's no ifs, ands, or buts about that. Of course, face-to-face, they come into your office, that's an 11. There are times with insurance that if you're doing telehealth, there's no copay for clients versus if they come in face-to-face, they have a copay. It makes no sense to me, but that's how a lot of them are doing it. Also, these codes are not for psychiatric because I figured if I'm just doing LMFTs, I not really needed to get into psychiatry. Any questions on codes?
Okay. Annalyn, are you going to send this to us later so we don't have to write it down?
Casey, you okay with our having it?
Yeah, I don't mind if you have it.
Okay.
I did try to email it over to Lynn, and then I found out Microsoft went down, so she might get the email. I don't know if you were on that email, Annalyn, but if not, I can email this to you.
I can look real quick.
Yeah.
Lord knows. Yeah, it looks like I did get it from Lynn, so
Okay,
I have
wonderful.
to pass on.
Wonderful.
Hey, Casey, I have a question about using the O2 code.
Yeah.
There have been some times where I have seen clients in their vehicles. Maybe
That's
they
O2.
drove to, that's an O2?
Mhm.
Okay, so anywhere
Yeah.
else but home. I mean, there is a whole list on the drop-down box.
Anywhere else but home.
Okay, because I've realized I have to be very careful about how I choose, because if I go one down, then I think the O3 code is prison.
Yeah,
And
we don't want to do that.
I don't want to put my clients in prison. So
No.
there's,
And a lot of another question I get about coding, or I get from providers that get confused. In the state of Florida, with the statutes and everything, and you guys probably know this, so I do apologize. A licensed provider can be anywhere in the world seeing a patient. Your patient has to be in the state of Florida. Like I have a provider
or whatever state you're licensed in.
Or exactly whatever state you're licensed in. I'm just talking about Florida since we're doing Florida. Like we have a provider that's in Hawaii, but she's licensed in Florida, so she's able to see patients telehealth for Florida. So, I do get that a question a lot too. So trying to remember the ones. Okay. That is not the where this is where I'm at. No, that's not where I'm at either. Hold on. Okay, I was writing notes down and I kind of got everything mixed up. So, what's quirky about billing insurance? You can get denials from insurance companies, and you can get there's denials and rejections. A denial actually processed through your insurance company, and your insurance company didn't pay for a reason. Could be they don't recognize the ID number for the patient, or patient's no longer eligible. But you also can get a rejection, and that doesn't come from the insurance company because the insurance company doesn't process rejections. That usually is your EHR or your clearinghouse is grabbing the claim first and rejecting it to you for specific reasons. So there is a difference between denials and rejections. Rejection just, you need to correct an ID, whatever, it lets you correct it before it actually goes. Insurance companies also follow the Medicare and Medicaid standards for charting, which is good practice regardless. And everyone's counseling center, we actually went through, and I have probably myself spent about 3,000 hours studying Medicaid and Medicare just to make sure we got the right, how it should be charted. We get audits like crazy. We're a big company, over 30 therapists, including psychiatry. So we get audited, and despite with these standards, knock on wood, and I'm going to, we haven't had anything come back on us because we stay with those standards. It is usually requested with insurance company that you have your charting done within 72 hours. It timestamps on that EHR when your charting was locked, and you want that 72 hours because you don't want anybody ever coming back going, why did it take you longer? How could you remember? Those kind of things. And then, of course, there are the certain things that need to be charted, including making sure your treatment plans are done timely. If I'm not mistaken, I think for a new patient, it needs to be done by no later than the third visit. I could be wrong on that, but if that's kind of what I remember. What else you kind of need to know is it can take 30 days for an insurance company to process and pay. If you're doing it all electronically, I've gotten payments within 7 to 14 days. So there is definitely good for being electronic. A lot of insurance companies now only take electronic. Diagnosis is always required, and there are certain diagnoses that if you use, and I'll probably say this 20 times, that you're going to get a denial for. They do not allow unspecified diagnosis codes. They do not allow Z codes to be primary. And you can't use a Z code if it's not associated with the current age of the patient. And I can't remember the code, but there is a Z code out there that a lot of therapists use for childhood trauma. And although you're right, and that does need to be noted somewhere, when you put that code with an adult, that will a lot of times get a denial. And when you have to work a denial, it could take another 30 to 45 days to get it taken care of. So I usually, if there's like some childhood trauma and it's an adult now, I usually tell providers, put it in your note. Maybe don't put it in your diagnosis if it's a Z code. But just make sure that Z code's not primary. Most insurances require a clearinghouse. I haven't met one that doesn't. Makes your life easier. What a clearinghouse is, if you don't know, is you have your EHR. You send the claims to a certain provider like Office Ally, or there's other ones like through Availity. That's your clearinghouse. So normally EHRs will do a quick scrub of your claims, and if there's any problems, they're going to let you know to fix it. But your clearinghouse also does a claim scrub. So now you've got two backups to make sure that everything is good. You send it to your clearinghouse then sends it out to all the insurance companies. And if you have yourself fully set up electronic, your insurance companies go back to your clearinghouse, and then your clearinghouse goes back into your EHR. They post payments. They let you know if something denied. It's, it's all there. So it is definitely good if you're going to be doing electronic, try not to do it yourself. Have that clearinghouse. A lot of them aren't that expensive right now. And a lot of them are
Casey,
attached to EHRs.
can you talk about, I think there's a charge per claim that you send for a clearinghouse?
It depends on your clearinghouse. Like with Office Ally, we have a monthly fee, and then we have a per claim charge. Depending on how many you do, is depending on what your per claim charge is. So it's kind of hard to talk about that. Um, but it is something that when you sign up, they let you know ahead of time, what those charges are going to be. I also, if I'm not mistaken, I think Availity might have one. Um, I just have not had the opportunity to really use anything electronically through Availity because we're too big to piecemeal like that for us. Like I said, we have over 30 providers, so I do try to keep it easy for us. Um, and just remember, you can also, if you decide that you want to be on insurance, you can also pick and choose what insurance companies you want to be part of. I'm going to tell you right now what the higher paying ones are. Write it down. Florida Blue, Aetna, Evernorth, which is the old Cigna, or yes, it used to be Cigna, now it's Evernorth, Multiplan, and Optum, and Magellan. Those are your highest paying right now in the state of Florida. It also depends on where your location is, what county you're in, and, all those fun things on what your rates are. But all these are hitting over $100.
Run that list for us again, Casey.
Sure, it's Florida Blue, Aetna, Evernorth, Multiplan, Optum, and Magellan.
Thank you.
Casey, those are all hitting at 100 for
They're hitting over 100.
individual or couple or family. Do you have a sense of that?
Usually, and it's really weird, but for the 90847, 90846, you get paid less. 90834 you can get paid less. 90837 is going to be your higher paying CPT code. Those are all hitting over 100. And of course, your 90791s are going to hit that. I can't remember all of it off the top of my head when it comes to the 90834. I do know, as you guys being therapists, it's a rarity that I see somebody that is so with it that in 45 to 50 minutes they finish that session. Normally, y'all are all doing 90837s. Have I seen an issue with billing 90837s, causing more audits or anything like that? I have not. I know I get that. I see that a lot on the um, Facebook billing things that I'm on, that providers are asking, hey, are you guys having a problem? I don't have a big problem with our big practice with billing 90837s. Every single one of us are providers. That's their main CPT code.
90837 is at least 53 minutes, correct?
I believe it. Yeah. 53 to 60.
So you're talking Swahili to me, but that's okay. You need to just because I don't bill insurance. I'm an academic. So, but I'm assuming there's somewhere that I could get that list that would translate for me what they each are.
All you have to do is if you plug in that CPT code into Google, it will tell you what the definition of it is.
Perfect.
It'll give you time too.
Perfect.
They're done by time.
So I just
only
put
know it because I
CPT
do it.
and then the number. Okay.
Yep. Just put CPT code in and one of those numbers and it'll tell you. There are some numbers that, and I do apologize, like the 90834 is not on here. That's individual psychotherapy. That's 45 to 52 minutes or something like that.
That's right.
and a 90832 is not on here. That's a 30-minute session. Um, you can bill for as long as you see somebody 16 minutes is a 90832. It starts at 16 minutes to 30, if I'm not mistaken. So, like sometimes you get on there and that patient goes, oh, I'm not feeling good, I got to go. But you've just spent 16 minutes with them. You can bill their insurance. 90832. Let's see if there's anything I needed to tell you else. That's all I can think about that one. Did anybody have any other questions about like billing insurance and those things I just talked about?
So do you recommend that people use like that office ally kind of thing? Do you suggest that they do that rather than or use electronic health records rather than trying to do it on their own?
Um, Electronic health records, I do like having a good EHR. It's just so much easier, I think, even if you're in a self-pay practice. Because the way you still have to follow HIPAA. I mean, you should be if you're in a self-pay practice when it comes to your records and things like that. And on electronic EHR, all of your paperwork is on there. You can electronically send it to your patient, or they have a portal that you give them and they log in and they automatically do the paperwork. Meredith has learned the wonderfulness of having that. So if you're getting like medical records requests, which you might not be getting a whole lot, but like if there's a lawyer or whatever, it's so easy to keep track of it. You don't have to buy any more of those folders. You don't have to worry about where you're storing them. Nothing. It's all on here.
You do, however, need to be sure that you have a professional will that has all of those codes and things like that, and that the person knows how to access your records at the time of your demise.
Yeah. Yeah. That's true. But it just makes it a lot easier. Even if you retire, you still will always have access to those records for the 7 years. You just keep them for 7 years.
Do electronic health records automatically delete them after the 7, or you choose?
It does not automatically delete them. That's when you decide whether or not you're going to get rid of the patient in your system.
I see.
Yeah.
Casey, is there ever a time where, with the advent of electronic records, I mean, I remember when sometimes we would have to do a paper claim, and we would purchase those forms. I would get them at
Yes.
Office Depot,
Yes.
and I still have a stack of those suckers.
CMS 1500s is what she's talking about.
That's correct.
Those are the claim forms. Yes, we still do use them for secondaries, or sometimes because we do Medicare. We're not Medicaid, but we do Medicare. Sometimes with Medicare, excuse me, if I sent a claim over, it won't let me do a corrected claim electronically, even though there's a code for that. So sometimes I will have to print one up and write corrected claim on it and mail it. And that's the only time Medicare now will accept a claim by mail. Everything has to usually be done electronically. They've really done on that. But sometimes with the secondaries, we do use the claim forms. There are EHRs out there. Ours just hasn't really gotten that way. It's getting there. But there are EHRs out there that you can do a secondary claim automatically through the EHR. Supplement and secondary are two different things. Supplement is an automatic. But so, yeah, we don't use as many as we used to, but we do use them occasionally. Still in the office, but not much.
Thank you.
You're welcome. Okay, so common denial reasons are timely filing. With each insurance company, your contract is you have 90 days some are 30. That from the time you see the patient, you have to file the claim. There are some that's a year, but nobody wants to wait a year for their money. I don't care who you are. So I normally say when you get that charting done in that 72 hours, get the claim off. But normally it's anywhere from 30 to 90 days is your timely filing limit. Your insurance company can deny if you don't do it in that timely filing. And because that's your fault, you cannot um, charge the patient. But if you can prove that you truly did send it, because any EHR is going to time when you sent that claim, and you can just print that up as proof that you sent it in time and mail it off, and they'll get it or upload it into a portal. So timely filing is a reason for a denial, and inappropriate CPT codes. Like, you're only allowed one 90791 per year per insurance. So if you continually bill 90791 and you've seen this patient already, you're going to get a denial. So
a 90791 is an initial interview, a
right.
diagnostic initial interview.
Some people forget to change the code and they'll bill like 3 or 4 of them and they get denied. You're only allowed to do one, right? Excuse me. Inappropriate modifier used. Like I was just telling you, a 95 is for telehealth. And you've got to make sure you put that right with the correct POS. I don't know if any of you guys have ever seen anybody who's in hospice. We have somebody that we do who's telehealth, and one of my assistants found out, and I'm going to give you the hospice code is GW. So if you see them in person, if they're telehealth, you would still put the 95, but you would put that also another modifier of GW. I'm just letting y'all know that. I'm giving y'all that information. That's a little freebie there, because that's something good to know. If they're in hospice, you're not going to get paid without that GW. And then non-covered diagnosis. We talked about the Z code. We talked about unspecified. They're really big on that because Medicare absolutely will not pay for an unspecified. And all the other insurance companies have gotten on that bandwagon. You might also get a denial saying, they want to see the medical record. Because what they want to do is they want to make sure that what you charted is the code that you use. They want to make sure you're doing what you're supposed to do. Depending on what your paperwork says, your consent to treat paperwork, once your patient signs that, you don't have to get an ROI to send for that. Like if I saw somebody, like say I got a denial for 1231 and they want to see the record, I can send that record without patient permission because I got the patient permission in my consent. Does that make sense? I don't need a separate ROI because I'm only sending one record, one chart for purposes of payment. That's usually my psychiatry department, but I just wanted to add that in there. Ways to avoid claims denial, keep that money moving. Make sure you're filing within the 30 days. Make sure you remember to put the correct POS with the correct modifier. Make sure you've got the right diagnosis. Double check, double check, double check. Make sure your client insurance information is up to date and correct. What that means is you want to, we only do this annually. Has your address changed? Has anything else changed? Sometimes they may update it with their insurance. They forget to tell you. And you just want to make sure that you have everything the same that they have. And then we start talking about following, the charting standards. So I can go into this. I wrote it all down. I told Meredith, I said, I don't really do charting standards, although I did those 3,000 hours of helping everybody get it together. I'm more than happy to kind of go over this template with you if you want me to. All right. So for a new patient, Treatment plan's got to be done by the third visit. You have to make sure that you have the appointment time, start and end time. You have the appropriate CPT code, which if this is the initial visit, is going to be a 90791. The appropriate place of service, the POS code. You want to make sure you have identifying information, subjective, which is like chief concern, reported mood, recent stressors, etc. Remark, and then like I think there's remarks I wrote this so quick, I'm sorry, remarks they made during the session, like if somebody was to say, I honestly feel like I'm doing well, or something like, well, concerned about alcohol use or mood swings, those are just quick little one-liners. The objective, which is the appearance, sensorium, relating, language/thought, and executive functioning. The assessment, which is the diagnosis, risk assessment, and assessment narrative. And then your plan with your interventions and goals. One thing I see when it comes to charting is too much information. There is a progress note and there's a psychotherapy note. And at this point in everybody's career, we should all know the difference. Psychotherapy notes are those more intimate notes. They're not part of the chart, although you chart them the same. Like with our EHR, you put your progress note, and then there's a little thing down at the bottom for your psychotherapy note. So when we print records, the psychotherapy note does not print because, as you all know, the psychotherapy note is highly protected. As a matter of fact, the only person that could ever read the psychotherapy note is when it's court ordered by a judge, and only the judge himself can read it. That's how protected medical or mental health records are. And I don't want to go into records, but the one thing I tell everybody is less is more. And Meredith can tell you that. I tell everybody that less is more. You need those good little whatever notes, put them in your psychotherapy. But just know that they can only be court ordered by a judge. If you're doing a follow-up, so you've already done the initial and now you're doing your follow-up, you need to make sure that your client name, date of birth, session duration, which is the start and stop times. That's really big with insurance. They're looking for those start and stop times. And if you're starting at 4 o'clock every time and ending at 5, we all know that ain't true. You went to the bathroom, 4:02, 5:02. Just be honest with your time. Start and stop times. You got to have those honest. You're going to make sure your CPT code's listed, your POS is listed, and your diagnosis code. You're going to make sure it's the service provider, which is like individual counseling, psychotherapy, couple psychotherapy, whatever you did for that session, what that main goal thing or what you did. The contact type, was it in person or was it telehealth? And I'm sorry, I meant to write this down and I did not. Annalyn, if you need me to send you an email with this verbiage, I can. But if you do telehealth, it should say something like, and Meredith, please correct me if I'm wrong, synchronized something, 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 which makes everybody know it was a HIPAA compliant telehealth session. You didn't just FaceTime somebody from your phone, which is not HIPAA compliant.
I can read you the statement in a minute if I have, because I have erased it sometimes when I'm charting because I'm just going fast.
Right.
And so I've had to retype it in myself in the note. So I will find it and read it aloud in a little bit.
Thank you.
Thank you.
You need to make sure you list who was present in session, and it could just be this patient and the therapist, or you can actually name your names. The problems addressed in the session, a treatment plan goals/objectives addressed, the last treatment plan review, put the date, therapist intervention, data, assessment, plan for the next session, date of service for the next session. Believe it or not, they want to know that. homework, if any was given, suicidal/homicidal risk assessment, and the mental health status. All that is, all this is Medicare. I just gave you guys what Medicare and Medicaid, that's what they want to see. It's that simple. Less is more. Yes.
I can read you what we use.
Thank you.
In the contact type, you're going to choose office, either they're in the office or they're telehealth. And once you do that, if you choose the option of telehealth, here's the statement that we use. Session using a synchronous telehealth service rendered via a HIPAA compliant real-time audio and video telecommunications system via therapy appointment, because that's the software that our system uses, and that's what I had used in my private practice. So we can include that I can put that in the chat if that would be
Thank you.
helpful.
Yeah. So when she's saying via therapy appointment, our EHR actually has a built-in telehealth capability. And as we all know, with technology, sometimes things just don't work out. We also use Microsoft's Office. And there are things in Microsoft Office that's HIPAA compliant, and one of them is Teams. So if our EHR telehealth goes down, they can actually email the patient through Teams and run it that way. We also use Nextiva for our phone service, which is all of our providers who aren't in the office or have actual phones. It's an app that they use that they can download onto their phone, and they each have their own individual HIPAA compliant numbers, and they can use that. So if for some reason that didn't work for Meredith through therapy appointment, she would either put Teams or Nextiva, because our Nextiva also does telehealth. So we have all kinds of backups to backups to backups. FaceTime is not one of them, guys. If you're doing FaceTime, don't do it. Don't do it. You're not HIPAA compliant. And even if you're seeing self-pay, protect yourself. Okay, so we kind of went through that, and I'm really sorry that I went off on that little rant. Okay. Where am I at? Did I already do this one? I went backwards. Sorry. I use a Mac product at work, and at home I have HP, so I go backwards all the time, and I do apologize about that. Okay, navigating these denials. Insurance companies allow corrected claims. A lot of this, when an insurance company, they have portals. One of the biggest one is Availity, and they have like a bunch of insurance companies are on there. So a lot of times for corrected claims, you actually just log into the insurance portal, pull up the claim, and they'll have a little thing there that says, if you want to correct it, or I can't think of the word that I want to use, but you can just do it through there. You don't have to actually go through a big thing. And a lot of times that just works, where you just, and it gets corrected. But you just want to make sure that as soon as you get a denial, that you work it. And when I mean work it, that is either that you get either on the phone with the insurance company, talk to them. If you do have to talk to a rep, make sure you get their name and a reference number for your call. Or if you log into your portal, it's going to keep track of it right there for you. When you get a denial, you have 30 days to work it before they'll deny it for timely. So you might not get paid in 30 days, but you at least need to get that ball rolling before that 30 days is up. With our practice, we keep the client informed, depending on the reason for denial. If it's something we didn't put the 9.5, that modifier, we did something wrong, we don't inform the patient. Anything else, we inform that patient immediately. And let them know that, hey, this is what's going on with this claim. I may at some point need you to jump in, or you may just understand it's going to be your responsibility. That, where it says keep client informed, all goes with your intake paperwork. We have looked at, going to primary cares, reading our paperwork, we fill it out. So we actually just redid our paperwork. And one of the best things that we found that we absolutely loved is saying our relationship's not with your insurance company, it's with you. So, Chris, I'm on a meeting. Can you not be in here? So like with our initial paperwork, it says a photocopy of your valid insurance card and your driver's license must always be on file. We will submit all applicable claims one time. Our relationship is with you and not your insurance company. Although we attempt to verify your benefits and financial responsibility with your insurance company prior to services being rendered, please be advised this is only an estimate of your coverage based on what information was given to us at the time of the inquiry. This verification is not a guarantee of coverage or payment by your insurance company. We highly recommend you also contact your insurance carrier to understand your plan benefits and any copay or deductible payment that may be required. And then we have another little paragraph that says claims not paid within 30 days, comma, denied claims or any retracted payments by your insurance company will become your responsibility. This protects us. I've had so many insurance companies go, but you can't just do that to a patient. I absolutely can. They signed it. And they go, oh, as long as you let them know beforehand. So on our policy statements, we have, this is kind of our policy statement. We also have what our late cancellation policy is, what the charges is for late cancellations, all about letters, things like that. It's, we've got it down to one page, but that is the most beautiful thing I've ever read when it says, our relationship is with you, not your insurance company. So you can do that. This is totally fine. Your insurance company can't say a word about it. But this is where it all starts because, it is going to happen. And, as long as you inform your patient immediately, hey, this is what happened. I'm going to go ahead and try to get the denial reversed. But ultimately, this is going to be your, this could be your responsibility to pay me.
Casey, can I give an example?
You can, yes.
Mm-hmm. Recently in my private practice, which I have had for 25 plus years, I was filing insurance and I had an overpayment recovery notice from Blue Cross Blue Shield or somebody like that.
It was.
This is a patient that I saw for a few sessions in 2023, and they were asking for their money back. That doesn't happen very often to me, but I think they were asking for like $575. And so I called the patient, and she, bless her heart, had already been proactive because she knew exactly what happened. There had been a change in her insurance. I think that's correct. And she had already handled it, so I really didn't have to do anything. I did not want to have to shell out $575 from that practice. So it can happen, but don't get spooked. If you keep good records,
right,
you'll be okay.
No, yeah, definitely don't get spooked and don't write them a check. Don't. The only people I write checks are Medicare and TRICARE. That's it. Everybody else, I don't write them a check because what they do is after 30 days of sending that to you and saying, hey, you have, they tell you why they're taking the money back. And you go in and check it. You make sure you get with the patient. You go, listen, they're taking this money back. This is what you owe me. You do all those things. I have, in my experience, then written the check to the insurance company Well, guess what? They came and took it back out of my claims. So then I had to fight to get the money back. So you don't write them a check, let them take it out of your claims. And so what
Your future claims, your
your
ongoing
future
future
claims.
claims.
Yeah. So say, and then you just keep track of it. So you know this is what they took, when they took, how they took it. But don't get caught in the now you've double refunded them and now you've got to wait 90 days to get your money. I'm just telling you that. Years and years and years of doing that. So if you're new to taking insurance, here's some contracting tips. Uh, have a representative for each insurance company. It's not required, but for bigger companies and it's got Blue Cross Blue Shield in here, but it's Florida Blue. It can be very helpful. A lot of
I'm sorry, what does that mean to have a representative for each insurance company?
it's when you go through and you call them, you can always go to like Provider Network, or every insurance company has a different name for what it is. And you get a provider that works for your county, and that's your provider rep. And that's the person who helps you contract. A majority of the insurance companies now all do it through portals. Like Availity.com is huge. They've got Florida Blue. I'm trying to remember them. I think they do Florida Blue and Aetna and Humana. Humana's another good one. Write that down. This is another good insurance to take. But they have a list on their portal on, who, who you go through to do that. Like Evernorth, which is the old Cigna, evernorth.com, you go right on their portal, join the network and answer their questions, upload what they need, and, they just kind of go from there. If you're going to be taking insurance, you need to make sure that you do a CAQH credentialing panel. It's ProView. Oh, I can't remember if it's ProView.CAQH. What that is that is a huge free to you um uh database that you go in and you have a login and a password for, and you put all your information, all your schooling, all your license. You upload copies of your license and your liability insurance. And insurance companies, when they are going to contract with you, they'll go to CAQH and pull stuff and make sure you keep things up to date, especially with recredentialing. Usually every 3 years you have to recredential with an insurance, and they'll just send you a reminder, hey, make sure your CAQH is up, and you just make sure that. A lot of people get confused where CAQH is concerned because they ask you a lot of questions. So it's not something quick that you're going to do because it's very thorough, and that's what you want. You want it to be very thorough. They're gonna want W-9, a copy of your license, a copy of your resume. So make sure you put those dates on there, and they're gonna want uh license, your liability insurance. Also, if you don't have an NPI, which is your National Practitioner Identifier, you want to make sure you have one. If you have an LLC or, like a business, you're going to make sure your business has an NPI also. So you would get your individual NPI, and then you would have one for your business. And your business is a type 2 NPI, you're a type 1. And which, of course, your business, you have a tax ID. If you do individual, it goes underneath your social. Most of all of them are processed online. So you want to make sure you've got your valid email. You check it frequently because they'll send you something and they may need you to send it. It didn't come through clear. Just keep a good check on that. You can also ask them for what the fee schedule is for your area before you contract with them. I do that with anybody who wants to contract. We take over 130 insurances. And that's the one big question I ask is, well, what's the fee schedule before I'm at the point I don't even need to. So, but I always ask. and different counties can pay differently. So don't get upset if your friend over in Melbourne's making a few more dollars. Melbourne does pay higher. Uh, I don't know if anybody knows what EAPs are. Those are employee assistance programs. So a lot of insurance companies have those with businesses. Those always pay lower because an EAP is to get you in and out the door. It's not long-term therapy. It's not meant for long-term therapy. It's meant for 3 to 8 sessions, and then you can use your regular insurance if you need to keep. So normally with those are the easiest one to contract with. But normally with those, I'll get to that. I'll just tell you now. So normally with the EAPs, after about a year, start requesting rate increases. Normally with your insurance companies that you see a lot of people for, after about a year, start requesting rate increases. Sometimes they'll do it. Florida Blue automatically does it annually. You don't have to ask anymore. Well, it does for our group, which I think it does for everybody. But a lot of them, at least every year, if not every other year, I'm sending out letters requesting rate increases. So you definitely can do that. And if you have a hard time because y'all are busy, you can hire a biller, or they're people that you can hire for specifically contracting you for insurance companies. A lot of people are scared of Medicare. Medicare is so easy. It's not scary. The hardest part of Medicare is if you are LLC, like you have your business and you want to keep it that way, you have to do 2 applications, and the one for the business is a little harder, but it's fine. It's all good. And I just talked to you about negotiating your fees with your insurance companies. And this is just kindly talks about, you do that. You just send a letter over email and they'll respond.
What sorts of negotiating points would one use to get your fee higher?
If there's something you specialize in, that's always good. Hey, just remind them what you specialize in, about how many patients that you see, and a waiting list. Like if you have a waiting period, like if it takes 3 months to get in with you, that's a little hard. We can see somebody within a week with our providers at our practice. So that's a really good point for me, that I can see somebody usually within 24 hours. And that's with my psychiatry department too. And that's unheard of. Most people are waiting 3 to 6 months to get in with the psychiatry. I can normally get you in within 4 days. So it's pinpointing your strengths. Can normally, how long you've been with them, how many patients, 50% of my practice or whatever. And don't forget, I specialize in EMDR or DBT or whatever it is that you do.
What are the kinds of specializations that are most attractive?
Right now, EMDR is big. DBT is getting bigger. I will say we're seeing a lot of requests for DBT. We actually just had at our center, we're getting ready to be the first in Central Florida certified center for the Marshall Lenehan for DBT. We're just finishing up our paperwork this year. So majority of our providers are DBT certified. And we actually just did a whole EMDR thing. It started last weekend, where we got this, somebody to come in and got everybody some really good rates. But EMDR looks good, even though you don't get paid anymore. DBT looks good. Just whatever.
Well, I was just going to say, those of us who are family and couple therapists, the fact that we specialize in divorced couples, or we specialize in marriage, Is that attractive to the insurance company, or they don't much care about that?
Um, it can be, because there's a lot of people that don't like to do couples, which is weird to me. Um, but most of them are LMHCs. Um, I yeah, I mean, I think anything that you are really good at, if you're one that's really good at with dealing with a specific couple issue, sex therapy, that kind of thing. I mean, just throw it all out there, throw it all to them, and
Okay.
you know,
This is
sell yourself.
this is helping to clarify something that I saw this week. I have
Mhm.
a student who is starting her internship at a Florida agency within the state. I don't remember exactly
Sure.
where. And I went and looked up the website of that particular agency, and all over the place they said that they were DBT specialists. And I was
Right.
wondering if you're, and they didn't say anything about couples and families, which is what the student needs is relational hours. And I couldn't for the life of me figure out why they would say that. This is now making sense.
Right. And there is a difference. There are people who, just like with EMDR, there's certifications or you cannot get certified. So you may be somebody who took a course in DBT, but you're not truly certified. So there is a huge, huge difference on that. And I know
So
a
the
lot of,
insurance company is looking for certification.
yeah, I mean, they'll let you just do, like you definitely want to put that you've got DBT, I can't think of what you would call it if you don't have the certification. Because there are a lot of providers that use DBT, and know about it, but it's very expensive in training. So to get certification and then just the different things you have to go through can be very, very expensive. I think our providers took almost 2 years. And that's a lot of time when you're running a full practice. That's a lot of y'all's time. So I understand why, they just have like they took the course or what have you. I'm not saying anything bad about that. I think that's wonderful. But yeah, any little thing, sell yourself. Any little thing that looks good. You've got to put it on there and you just gotta, I think everybody's great at what they do. Yes, ma'am.
I think if you are um, anything that you practice that is evidence-based, they like.
Hmm.
If the research shows that it's evidence-based, or when you fill out the application to get on a panel for insurance providers, you will see that there are 3 or 4 columns of boxes that indicate what kind of work you want to do. Everybody does anxiety, everybody does depression. But if you can distinguish yourself in some
Right.
way, um, for me, like I will put something like, there might be a box that says Christian counseling, or there might be a box that says
Right.
LGBTQIA, or if there is a box that says sex therapy. Those are things that um, they need to know. Or if you like to do adolescents, or you do
Huge.
children, yeah. If you do children with young ones, say you'll see kids 6 and up. They like that because they are presented with situations, and it is not uncommon for me to get an email weekly or
Hmm.
more from an insurance company saying, we have a person who is 25 and struggling with depression, has some suicidal thoughts, is autistic. whatever that is, if you know about autism and you're trained, you can alert them that you have a place in your schedule and you will get that client. You
Yeah.
will not have any trouble with
Yep.
getting clients, especially if you market yourself in certain ways.
Yeah.
Let's have
There,
another
yeah.
question.
Hmm.
Okay, so I know that clients will look on their insurance network to try to find a therapist. But what
Right.
you just described, Meredith, is that the insurance company is trying to find a provider. So
Yes,
how
they'll
does
do
that
that.
typically work? Does the client go to the insurance company rep and say, "Hey, I'm looking for a therapist," and then they'll go look for
Nope.
someone in their network?
Yeah, they
That
call the number on the back of their card and they tell them, where they live, the area, and how many miles they're willing to drive. And then the rep will start asking specifics about, what you're looking for, and they'll plug all that in and therapist will come up.
I see.
And
That's
so
why you
they'll
have to
they'll
have
give
all
them
that
a list.
information in
Hmm.
your profile so that you'll pop up to the
Oh
top of
yeah.
that list.
Yeah.
But the other is true as well, that the client might go look on the network and do that kind of research themselves.
Yeah, just like for
Okay,
my personal insurance, I can go into my portal and I'm looking for this, 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 and this, and it'll pull up everybody that's marked those boxes on that credentialing application. Yeah,
gotcha.
that's what they're looking for. And another big referral source is Psychology Today. We get a ton, we get a ton of referrals from Psychology Today.
And this is directly from clients. This is clients finding you on site today that then contacts you.
Yep.
Gotcha.
Yeah, because you
Gotcha.
kind of list the insurance panels that you're on.
Well, speaking of, can we go back to the very beginning? I don't take insurance. I'm cash only.
Sure.
And very teeny tiny. No, I don't mean the beginning of this. I mean the beginning of the process.
Right.
Um, well, I've never taken insurance. What is my first step in starting to take insurance? Do
The
I
first,
do I contact Headway or Ally
no,
and no, I don't do that.
not, I
Okay.
mean, no, because basically when you do that, you work for them.
Ah,
Um, yeah. So if you want to continue to work for yourself, there you kind of do it yourself. The first thing I would ask you if you were coming to work for me,
so I'd still
would
be working for somebody. I'd still be working for somebody.
no, you could work for yourself, but I'm just going to go through my questions. So the first thing I ask is, okay, do you have an MPI?
Right. So I have to go get some of these credentialing things. Okay.
Right. Yeah. You've got to have an MPI. Excuse me. You got to get your CAQH done. So there's certain things you have to have first, then you go to the insurance companies.
I see.
Yes.
And then when you say go to the insurance company, I literally go to Magellan's website and
Yep. You just put in, yep, you can just Google Magellan and they'll tell you how to join. A lot of that happen, a lot of that's what you do. There is it's called availity.com, availity.com. And that's seems to be like a one-stop shop for a lot of things. And they're just getting bigger and bigger and bigger. So like Florida Blue, if you wanted to try to credential with them and you did Florida Blue, it would tell you to go to Availity. And what you do is you would
so Availity is different from Headway in what way?
they don't give you clients, you don't see patients through them.
I see.
Availity is like you can do claims through them, you can verify benefits through them. There are certain insurance companies that's where you have to go to get on it, but they don't give you patients. You don't use it as an EHR, nothing like that.
That's with
Gotcha.
Headway or Alma.
I I aren't those ones that you are actually a 1099 for? Headway and Alma?
I'm sure. I
Yeah,
don't know.
it functions
Yeah.
as a group practice. Like they'll credential you, but it's basically just like joining a group practice.
But you're 1099 instead of,
Yeah.
yeah.
So here's
All of
another
our,
question. Let's say I go to a Headway or an Alma and they credential me.
hmm
Do I own the credential or do they own the credential?
they own it.
They own it.
It's
So if I
underneath their
leave
tax
them,
ID.
so if I leave them, I have to go redo this all on my own or go through Availity. And then if I do it through Availity, it's my credential.
Correct.
Gotcha.
So what it
I
is you have
appreciate
group
that.
contracts. Like I have group contracts. So any provider that comes into our practice goes underneath our group contract, which is underneath our tax ID number.
Right.
Now,
So Headway is like your company in
right,
that
it's
way.
a group. So they're gonna credential you underneath their tax ID number. Now, if you know who they credentialed you with and you contact that insurance company and you say, well, I'm already credentialed underneath this tax ID number. I want to add a tax ID number. Sometimes, depending on the contract that they have, you can add your tax ID number as an individual provider and not have to go through all the hoops. Sometimes you can't, but sometimes you can't.
Is there a relative benefit between those two options to do it under a Headway or under a company versus doing it all on your own?
Um, I don't suggest going like to, if you're just wanting to get on insurance panels and you're wanting it to be easy, um, everything comes with a price. Everything's really not that easy. So you've got a chance of however they've got their contracts written with insurance companies that you just did that and you still can't get on panels yourself through them to be, I might not be making sense. So if you're under a group, sometimes depending on how that group contract is, you can't call as an individual and go, can I add a tax ID? Sometimes you can, sometimes you can't. It all depends on how that contract is. I don't know enough about them to say one way or another. I know with us, 95% of my contracts are group. I think I only have like a couple that aren't. And how I have my contracts with groups to stop people from doing what you're talking, from coming on just to get on panels. Me putting in all that work just to get you on a panel for you to quit. I have mine set up that won't work for you. You're gonna have to redo it on your own anyhow.
Gotcha.
I don't know how each company does theirs. Some might not do theirs like I do mine. I've been burned too many times.
That totally makes complete sense.
But listen,
like you said, if you go through the effort to impanel somebody, you expect some work out of them. And so let me ask you this. So is the rate different? Is the rate different that I'll get if I get on by myself versus I am impaneled by a group?
It can be.
Mm.
It can be. It can be a little bit lower.
With which?
If you're individually instead of with a group.
So if I do it on my own, I might get paid less than if I do it through the group.
You might get paid the same, you might get paid less, yes.
Okay. Okay.
Just depends. It
Interesting.
depends on the insurance company.
Sure.
Depends on where you're at, stuff like that. I know with as many years as we've been doing this and with as many providers and the fact that I can get somebody seen within 24 hours and I can do that, I do get higher rates. But we've also been with these panels for
you provide a service to the insurance company that they value by increasing your rate.
Yeah.
I had something else.
Sure.
It went away. Whatever it was, it went away.
I have a question.
Mhm.
So I've heard multiple things about this, and I'm think I know the answer, but I just want to confirm that from your knowledge that when we're talking about people who are who can bill to insurance, we're only talking about services that are provided by fully licensed therapists, like a student intern or a registered intern would not count.
Right. A student intern cannot bill any type of insurance. Uh it can't happen. A
Now,
registered
that's in the
intern,
state of Florida. That's in the state of Florida. To your
yeah,
knowledge, is it different in other states?
sorry. I
Another
apologize.
part you heard from. Um, like for instance, I have students in New York State, that they tell me that their work is billed to insurance.
Right.
So
The state
is
of
it
Florida you
possible that
can.
other states do? Okay, so you can.
In the
Now,
state of
Lynn,
Florida, you cannot bill insurance for a student intern, but for registered interns, you can, as long as you have the supervisor, and it's an insurance company that allows you to do that. Some of them don't, like some smaller ones don't allow supervisors, but
so the bigger ones will allow supervisor billed work of registered interns.
yeah.
Okay,
And you can always ask them, hey, I've got registered interns, but you can't credential a registered intern.
got it. It's the supervisor that actually holds the credential.
Correct. And you're billing under the
Gotcha.
supervisor. You're billing under the supervisor who's signing off on the registered interns chart.
Gotcha. Now, I remember the question that flew away. You said that before you go credentialing with a company, that one should look up what their fee schedule is. Is that just readily available on their website?
You have to ask them.
So you have to send them an email or something and say, send this to me.
Yeah.
Gotcha.
The ones I gave you, like I said, are higher. But yeah, normally when they send you a contract, there's a fee schedule attached to it, and you don't even have to touch the contract if you look at the fee schedule and go, nope. But I wouldn't just at that point discard it. If it wasn't to where I wanted it to be, I would actually get in touch with the rep at the insurance company that sent it to you and go, can we negotiate this? Because you never know. You never know.
Yeah, yeah.
I've done
And
it.
yeah, you have done it. Okay.
I
Once
have
upon a
done it
time,
successfully.
people would tell me that they got on the little insurance companies because they couldn't get in the big ones, that the panels were closed and you couldn't get in. Is that still the case?
It can be right now. Florida Blue is closed. But the rest of them aren't. They're all good. Right now, Florida Blue hired this, I think this is their third or fourth one, hired a company that does their mental health credentialing. It's called Lucet, Lucet. And they're closed right now because they do have, depending on the area you're in, because they do have, once they get so many providers, they kind of close it off so it's not so saturated. So I say depending on the area you're in, it depends on the county that you're in.
Do years of experience count for anything?
It does help.
Okay.
It does help. And normally,
right.
they want, like, normally there's a post licensure. It could be like a year, it could be 2 years, it could be 3 years.
I don't know what you mean.
That they want you licensed before they'll contract you.
Or at least that long. Okay. I see.
Yeah. Some of them don't
Gotcha.
care. Some will just take, but some of them do have requirements like that. And they tell you up
Okay.
front.
Okay. Well,
Trying to
so
think of all
Tommy,
of them.
there's hope for us.
Yeah, there's hope for everybody. Hey, listen, Medicare just started taking LMHCs and LMFTs.
That's
There
right.
you go.
That's right. I had someone today text me saying, I understand that Medicare won't take LMFT, LMHC. I said, oh, no. They sure as hell do. Started since 2024, 24,
Yeah.
25, 24.
24.
24. Yeah.
That was a busy month for me.
Yeah. And does Medicare pay well?
Somebody asked me that and I went, oh my gosh, you shouldn't have asked me. I can't think of it. They don't pay bad.
Well, okay, what's bad? Give me the bad
You know
number.
what? I don't, I was trying to think of a fee schedule and I can't even, I can't
I
even
mean,
think of
I
the fee.
understand BetterHelp starts you at $35 an hour, okay, which is laughable.
So I don't know their exact fee. I'm contracted with them. It's definitely better than I can't even because I know some of them are very low, but it's definitely less than Florida Blue, Magellan,
Yeah,
Aetna. So it's like in the middle ground.
yeah.
little,
The ones
little,
I gave you, it's less than those. Um, but you don't really have a problem with getting paid. They pay you pretty quick
okay,
too. Do you bill
okay. So,
electronically, Tanya?
Yes.
Yeah. Yeah, I don't even think they take paper submission anymore unless it's corrected claim.
mhm. My understanding that TRICARE doesn't pay well, so when I have a colleague who takes TRICARE, he says it's his pro bono work.
You know what? It basically is. I think that for a 90837, I think for I want to say it's maybe 70, 65, 70. It's weird
Okay.
because they do percentage, and that's not high when you're getting, I'm gonna tell you right now, Optum's 110.30, so it's $110.30. That's what Optum pays for a 90837. That's pretty good.
And I believe someone said earlier that unfortunately, often couples and family is actually paid less than individual.
Yes,
And is that across the board or is that only certain companies?
across the board.
Uh, they hate MFTs. Why is that?
Well, you've got to think they still want you to with the 90847, it's still 45 minutes. So it's not a higher code as far as time. You can spend an hour with them. They don't care. They're going to pay you for that lower, just like a
They're
90834
going to
is
pay you
lower.
less and expect you to do it faster, which makes absolutely no sense. Actually, couples
Absolutely.
take longer.
Yes. And God, there was something
Well,
else
all
that
right. So one might do insurance for individuals because of as a way to kind of beef up the practice, but then do fee for service for couples and families so that they can
you
get
can,
an
if
equal
you
amount of
take an
money.
insurance, you can't pick and choose. If you
Really?
if you contract with Aetna and you've got somebody that comes in and it's going to be a couples or a family or whatever, no, you have to use the insurance.
Oh, you're saying if they come, if the family or couple comes in and they have it,
Yeah,
that.
yeah, you can't pick and choose. Like you're only going to do individuals.
So
If you
if I use Aetna, but I have a couple of family and they come in with an insurance company I'm not with, then I
That's
can I
different,
can do fee for service with them. Gotcha.
right? Yeah. And you have to remember that your fee has to be higher than the insurance fee schedule. For example, with multi-plan, there's a code they pay $130 for. So say your fee schedule is 120 and you only bill 120, you're missing $10. So your fee schedule needs to be higher than what the fee schedule rate is with the insurance company.
Oh, okay. And is that so that the insurance company's fee looks more attractive so that people will use their insurance?
No, it doesn't really have anything to do with that. Insurance company's only going to pay you what you bill. So if you bill lower than their
Okay.
fee schedule, yeah,
Okay, I see. You're all right, again, that's assuming you're working with that company. Gotcha.
right.
Gotcha. Okay.
Yeah.
Okay. Interesting. But you're at if I'm working with Florida Blue and my fee is 120 and they pay more than that, it doesn't matter who, even if it's someone who doesn't have Florida Blue, if my standard fee is less than what one of the insurance companies are, that's going to be a problem.
Right. So say your fee is 120 and Florida Blue pays 150. You're going to bill it for the 120 because that's what your fee is. They're not going to pay you 150. You're only going to get the 120. You
I
just lost
understand.
yourself. So
I understand.
yeah,
Okay,
that's
so
why,
so whatever fee you tell the insurance company has to be higher than what they would,
yeah,
than they would pay.
I
Gotcha.
usually recommend as therapists you have an across the board. So especially if you're dealing with insurance, you can have a sliding scale rate, but if you're dealing with insurance, you have across the board. So ours for our providers, for our therapists, is 175. We're 175 across the board. So we are higher than our
Right.
highest rate. Yeah.
Gotcha. Gotcha. That makes sense. That doesn't mean that you have a whole barrel full of fee for service people who are paying that. Because
Correct.
most of your people are coming in under insurance, but your advertised rate has to be higher. Gotcha.
Mhm.
Now,
Yep.
there are many things that people do that are now making sense that never made sense to me before.
Right.
So I really appreciate this.
Yeah, oh yeah, no. So you can have sliding scale, like we have sliding scale rates. And we actually set up a freedom clinic that we have for our student interns because we're teaching center also, not a facility, we're a center. Um, so our student interns run our freedom clinic, who is supervised by our clinical director and our chief clinical officer. So that, no insurance, it's all out of pocket. But with everything else, everybody else, it's across the board 175, except for psychiatry, of course, it's a lot higher. Um, yeah, that way we can do that. But we have sliding scale rates that we use if a patient doesn't want to see a student, they want to see a registered intern. We have special rates for them. And then we have special sliding scale rates for our fully licensed. And we have sliding scale rates for our psychiatry department too. But
Mhm.
yeah.
Mhm.
So you're able to do that. And if you have a patient if you're on an insurance panel and say the patient has a high deductible account, so they have a $10,000 deductible and they're just like, man, I can't afford that. If you're meeting a deductible, say for a 90837, your agreed upon rate with the insurance company is 150. And that's what you would collect. You wouldn't collect your 175, you would collect your 150 from the patient because you can't charge them above the rate. And say that patient goes, okay, well, I have a $10,000 deductible. I can't afford $150 each time I come in. Can you give me a sliding scale rate? What you would have them do is sign an opt out of insurance form with you. And then you would have them sign a sliding scale rate at whatever you decide to do.
Gotcha.
That means they can't file insurance. They opted out of it. This is what y'all decided.
That makes sense. Yeah.
Yeah.
So there are ways to make that work, but there's extra paperwork to clarify
Yeah.
all of those things.
Yeah.
Gotcha.
Because you don't want the insurance
Gotcha.
company to drop your contract. So you can always, and if anything ever happens, you can say, oh, no, no, no. They opted out. Here's my paperwork. And, then they can't try to say you did something that you weren't supposed to.
But then
Right,
again, their
right.
payment doesn't count towards their deductible, their payment with you.
Right. The opt-out means that it doesn't bring down their deductible.
Right. If they opt out of it, then it doesn't go toward the deductible. Correct.
Mhm, mhm.
Which you would be amazed at how many people think that they can't meet their deductible through mental health, that they have to do it all through primary care. It's like 9 times out of 10,
Oh,
you're going to meet it quicker with us than you are anywhere else. But yeah. Trying to think if there's anybody have any other questions.
I have a question. I've always heard, I don't know for sure, but if you're billing an insurance company for, say, 175, and so you keep your insurance billing at that rate. Well, the flexibility, if you do a sliding scale, you have to do that for everybody, even your self-pay, no insurance people. Am I right or wrong? I don't know.
I might not be hearing the question right.
Mhm.
So
in other
if
words,
you're
I can't create a sliding scale for this one and then a different sliding scale for that one and
no,
a third sliding scale. I can
no,
negotiate any fee I want.
do whatever you want. It's your practice. The only thing that it is required, and I know I'm going to say this wrong because I can't think of the name of it, is they came out with the new law where you have to make sure the patient understands what you're charging them before you see them. So you can't tell a patient, oh yeah, I'll do that paperwork for you
The
without
fair
telling
estimate.
them.
I think it's fair
Thank
estimate.
you.
Yeah.
Faith, the good faith estimate.
Mhm.
And same with sliding scale. If you have this patient that can afford to pay you 100, but this patient over here can only afford to pay you 50, you can do that.
And then bill to the insurance at the fee
No,
negotiated with that. No.
you cannot. If you do a sliding scale, you cannot bill to insurance.
Okay.
So
If
sliding
you are
scale is only for fee for service out of pocket. Yeah.
only for fee for service, one of the big things that providers do wrong, and if you don't take insurance, you don't know this, is okay, excuse me, okay, your rate's 175, you're giving them a $75 discount, you're going to do sliding scale for 100, and they want a receipt to send into their insurance. No, they don't get the $100 receipt. They have to pay you the 175 because they're going to get
And
reimbursed.
but okay, so they have to pay my 175 and then I do the super bill that goes to the insurance company.
But they have to
Gotcha.
pay your full rate if they're going for
Full fee.
insurance reimbursement.
Right. But if they're going to pay less than that, if I'm giving them a discount, that's when they have to say they're opting out of the insurance.
If you're not paneled, if you're not credentialed with that insurance, so you don't have to file that insurance. You don't have to do anything with that. But if I came to you and said, well, I have this insurance and I know you're out of network, I want to make sure I'm saying this right. I want to make sure my mind's going right on this. In our practice, any patient that comes in that is, we are not filing the insurance for them. If we have any patient that comes in that we are not filing the insurance for whatever reason, in network, out of network, whatever, and they want a receipt so they can pay us this, and then they're going to turn it into their insurance, they have to pay us the full fee. We don't do sliding scale with that.
Whatever your established advertised rate is.
Right. Because this is what that's our rate across the board. And if an insurance company goes, well, okay, you saw Joe, but you charge us 175, but you only charged her 100. You don't want that. So if anybody, for any reason, is getting one of our receipts to file to insurance, and we know, they have to pay the full fee for us.
That makes sense because you're essentially signaling to the insurance company that you would take less.
Right. And you can get your contracts dropped. You don't want your fee
Gotcha.
schedule dropped. Yeah. Mm-mm.
That makes sense. That makes sense.
So we keep it across the board. Sorry.
Right. So if I'm
Trying to
going to
make sure I
cut,
said
if
that
I'm
right.
going to cut, yeah, if I'm going to cut my rate, that means they cannot use their insurance. If I'm going
Right.
to cut my rate further. That makes sense.
Absolutely.
Tommy,
They can't.
does that make sense to you?
Me? Yes,
Yeah.
absolutely.
Okay.
I have a client, just as an example, and my fee, say, is $175.
Mm-hmm.
Well, they travel the world, so they only come in periodically because they're not home a lot.
Right.
So they may want a 2-hour session.
Mm-hmm.
And when you bill, if I were billing insurance, would I bill 2 hours? Because that's what they're paying. He's paying.
Right. So with people who come to us and say, hey, I want to do a 2-hour session. I want to do an hour and a half session, whatever. We let them know that we only bill that first hour to insurance, and the second hour they have to be self-pay.
Okay.
You can
So
do that.
we will bill one one, when we set it separate, it's not a full 2 hour slot. It's two separate times on the
Mhm.
schedule. And 1 hour goes because we let them know up front, we only will bill 1 hour. There used to be a 2 hour code, a 90-minute code. I think it was
Mhm.
90839, and they took it away from us, saying that now 90837 covers that. I'm sorry. I am not about to let you see somebody for 2 hours for $110 or 130. You're worth a little bit more than that.
Mhm.
So we let them know in advance. Well, we're more than happy to do that for you. They're going to be they're going to be scheduled separate. One is going to be going to your insurance, and the second hour will be self-pay by you. Or just keep your first hour,
Mhm.
you know.
Okay. And
Yeah. No.
do you give the client, because they're say if they're going to send it into their insurance, you give the client the 175 1 hour on
Right.
one bill, and the second hour
They eat it.
self bill. I mean,
Mhm.
to the client.
Right. Well,
Right. Okay.
since we take insurance, if we would bill that first hour to insurance, the
Hmm.
second hour would be underneath self-pay, and they would have to pay it.
Hmm.
And they will can't, yeah, they can't, and we let them know you can't file your insurance for that second hour. Sorry.
And if you are out of network and you give them a super bill and you say that you charge them 175, which is what you have to do, you have to charge what your full rate is. You better take that once, you better collect that 175. You can't say you charged it and then collect something less. That's fraud.
Right. You're still doing fraud. Yeah. Even if you're not, it's still fraud. You don't want to do that.
Even if you're trying to be nice, it's
Yeah.
it's fraud. Yeah.
Yeah. Yeah.
It's better that they not deal with their insurance company at all or
Mhm.
even opt out, and then you can negotiate that lower fee.
Right. And
Gotcha.
I will tell you guys this, anybody who's thinking of, okay, I'm going to take insurance, I'm going to hire a biller, da 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 da. With my company, I I'm I'm a CFO, but I also own my own business. My clients I've had for 27 years, 27 years. Um, I if something happens to me and I'm the only one that's got it, then what are you going to do? I always tell my providers, get your EHR, set me up under that. It's usually free to have admin. That way I'm logging into your EHR and I'm doing everything there because God forbid if something were to happen to me, your life doesn't stop. Your business still keeps going. I do know there's billers that go, nope, we put it all in this one and we keep it all over here and you can't see it. No, you need to be able to look in your EHR. You need to be able to make sure those claims are getting paid. You need to be able to see what your person is doing. Be very leery of somebody who won't do that. And because they're underneath your EHR, you have total control. And if your relationships with that person ends, you just inactivate them. They can't log in anymore, but you still have everything. And like with our EHR, um, I get to see records because we'll do that. But like my front desk staff can't read records. They don't have that permission. So there's permissions you can give certain people. But I'm not going to go into naming names and stuff, but there is a somewhat large billing company that would not use somebody's EHR. They would collect the information from you and they would put it all into their billing. So there's like no billing on this provider's in her EHR. She has no idea if anything's what hasn't been paid or any. There's no reports. And this person over here, this company just committed suicide. I feel sorry for them. I'm telling you a true story. I feel sorry for them. But every client that company has, they have no idea where they're at. They have no idea where they're at with their billing. They have no idea what's been billed, what hasn't been billed, what hasn't been paid, what needs to be paid. You as therapist, it doesn't stop. You have to keep going. just because somebody passed away or what have you, you still have to keep going. This is your livelihood. So these people that are with this company that have hired them as billers, they have no idea where they're at. They
Mhm.
only go by the reports that they're given. And I'm going to tell you right now, you can fake any report you want to. But if it's on your EHR, you can see it. There's no faking it. There's no faking it. You can see it and you have total control, and you can look at your biller and go, what's happened with this one? Why is there's nothing on here? What's happened with this? I'm telling you, as a biller, that was, when I first started, 27 years ago, it wasn't like you can do them now. They weren't cloud-based and all that. So I did have all my providers in one, and they didn't really have access, and I hated that. Now, I had trained my husband, believe it or not, on how to get that information. If something happens to me, this is what you do to get this information to that provider. They're gonna need it. And then fortunately, when everything became cloud-based, it made it a lot easier. You always want to know what's going on. You always want to have your hands in it. Just to see. I know y'all aren't business people, you're therapists, and that's what you need to be able to do. But you also got to check and make sure that the business is working and that you get your money coming in. And so now, so as soon as all that came out, all my providers, and Meredith can tell you, hey, you need to get this. And I have logins for her, and at any time she can take me out. And she doesn't pay for me. She just pays for herself. So you just, if this is something that you decide to do, just keep that in mind. Be a little leery of the ones that will only let you use theirs and you won't come into yours. And, I'm available with any questions. You're more than free to ask me any questions. Y'all know Meredith. She knows how to get in touch with me. If you're
And
going to go,
Meredith, you have your hand raised. What's up?
I wanted to mention the idea of having I have a Casey as my business associate, which
Mhm.
is which is a document that she signs. Uh,
Business
I think
associate agreement.
yes,
Mhm.
and you need to do one of those
Yep.
with whoever you contract with.
Yes.
Um,
Business associate agreement. It's a HIPAA thing.
Even if you do with like one of the EHR companies, like
They
simple
automatically do
practice and
them.
stuff like that, they
Yeah,
automatically. Okay.
it's all that's automatic. Anybody like Meredith didn't have to do a BA with me. I sent her the BA, my business associate agreement. Um, because that protects her if I go start running my mouth, which I'm not going to, obviously. Because listen, at the end of the day, I'm done. Oh, I don't even want to talk about it. A lot of times I walk in, I'm like, nobody talked to me for 45 minutes. I need a break, because I've had so many people in my ear. But yeah, they just protect you guys.
Mhm.
They even
Good.
say like if you're going to leave stuff out from your cleaning people, you should have BAs with them too. But mhm.
All right.
Well,
Anybody that might see information.
does that go back to that professional, it's not a will, is it a trust professional where somebody that you entrust somebody to take over your cases? What is,
The professional will. Yeah, that's a
yeah,
professional
Okay.
will.
Yeah,
Uh-huh.
no, a
Yeah.
BA is somebody that you're going to be contracting with that could potentially see PHI,
mhm.
you know.
Yeah. Yeah. So everyone signs that confidentiality agreement, so to speak.
Right.
Yeah. Okay. Aaron, did you?
I'm sorry, you said what?
I said, do you have any questions? I thought I saw a bubble over your head.
No, I mean, it probably is lots of bubbles up there. No, I've
7:30.
no, I've been taking a ton of notes, so thank you very much. Yeah.
Yeah. Yeah. All right. Very good. All right. So, uh, uh, Casey, I don't know if your contact info is in your PowerPoint.
It
Um,
is not.
it is not. All right. Well, so I will get that from you. go ahead and put that into chat for me. And so what I'll do is when I send this out to the FFTA members, I'm going to include that statement that Meredith put into chat. And your contact information so that those of you listening to this recording will have that information in the email that I will send to you. At this point, we're already 15 minutes over. So Casey, thank you so much for all the extra time.
You're welcome.
And I so much appreciate you. So
Listen, I'm
everyone,
passionate about it. I did give you my
well, I
personal
love that.
email in the chat. I gave
Okay.
you my personal email.
Would you prefer that, or would you prefer a business email?
I use that for my business outside, so I
Personal?
don't get,
Okay,
yes, so that I don't
very
get a whole
good.
lot of stuff in my
Very
CFO
good.
email.
So people could contact you for a consult, and as they wanted to learn after this recording, they might
If you had
reach
any
out to you and get
specific
some more
question, yeah,
details.
if they have some
Yeah,
specific questions, I don't mind answering. I mean, anything to
that's
help you
lovely.
guys, for sure.
Oh, Meredith, you buttered it up for us. Thank you.
I love Meredith.
All
Thank you
right,
so
thank you so much. And everyone have a good evening.
You too.
Thank
Bye, guys.
you. Thank you
Thank
so
you.
much.